Welcome to our Permanente Live webinar, Healthcare's Quest for an AI Strategy. I am Stephen Parodi, Executive Vice President with the Permanente Federation and Associate Executive Director with the Permanente Medical Group, and I am pleased to serve as your moderator for what should be an informative and engaging hour. Because our focus today is on healthcare IT, I encourage you to stay engaged with the conversation using the hashtag PermLiveAI. And please submit any questions using the Q&A function in this Zoom meeting, and we'll be diving into some of your questions later. I'm excited for our panel today. We see the results of artificial intelligence in everyday use, from chatbots answering questions on websites to programs used to build self-driving cars. But widespread AI use in healthcare is still in its infancy, holding more promise than having been fully implemented in practice. That's why it's important that we as physicians, technology experts, and all of us with an interest in healthcare dialogue about computers and how they will inevitably shape the future. So thank you for joining me for this discussion. We brought together a group of esteemed thought leaders from a variety of healthcare organizations and tech companies from across the country. Dr. John Halamka joins us as the president of the Mayo Clinic platform, which is a portfolio of businesses focused on transforming healthcare by leveraging AI, connected healthcare devices, and a network of trusted partners. Dr. Michael Howell is the Chief Clinical Officer at Google Health, where he leads a team of doctors, nurses, and other clinical experts who focus on technology and can help improve real-world health and healthcare. Dr. Ed Lee is the Executive Vice President of Information Technology and the Chief Information Technology Officer at the Permanente Federation, and also serves as an Associate Executive Director at the Permanente Medical Group in Northern California. Together with his partners at Kaiser Foundation Hospital and Health Plans, he leads the strategic development and implementation of health IT at Kaiser Permanente and is focused on expanding the accessibility of health information and decision support tools for more than 12.6 million members. Dr. Vivian Lee is the president of health platforms at Verily, an alphabet company whose mission is to apply digital solutions to help people live healthier lives. She works closely with Verily's clinical and engineering teams to develop products and platforms that support the successful transformation of health systems to value and advance health with patients, caregivers, and communities. Dr. Fatima Farouk joined Salesforce earlier this year as its Chief Health Officer and Senior Vice President. She brings her experience as a practicing physician, Chief Medical Officer, and Clinical Technology Strategy Consultant to Salesforce's Health and Life Sciences program. Thank you all for joining us today. So John, I'm going to kick it off with you, and I'd like to just sort of ask you, can you share with us what you're doing at the Mayo Clinic platform? What does the platform envision for the future for bringing systems together to create the best AI and ML algorithms to clinicians and patients?
Well, hey, thanks for that great question. It all starts with curated data. And I would argue that if you look at the EHR data, it's messy and it's incomplete. So one needs to ask the question, can you take phenotype, genotype, exposome? Can you take all the images, all the telemetry, all the patient-reported outcomes data, organize it longitudinally, birth to death, and then make it available to investigators using what I'll call an AI factory? And that's what Mayo did. It's very hard work, right? We actually took a couple of years to cleanse the data, to, in effect, remove the people living to 150 years, or the men having babies, or the women having prostatectomies. We then organized the data in such a way that it's not episodic, it's longitudinal. And we de-identified it so there would not be a lot of tricky IRB, human subjects, or privacy issues around the use of the data. But it is still stored in a secure cloud container with tools on top of it for all of our clinicians and all of our investigators at Mayo Clinic to create models. One last comment, creating a model is insufficient. One needs to test the model, validate the model, use data even outside of the training set. So we've also established a variety of collaborations nationally and internationally to test the models to make sure they're fair, unbiased, and useful for purpose.
Well, thank you, John. And Mike, I'm going to turn to you next. And we, of course, can't have a health information technology webinar without inviting people from tech giants like yours. So how are you thinking? You are a practicing clinician. Can you talk to us a little bit about Google's vision for AI in healthcare? And maybe touch upon a little bit of that testing validation question, because I know that you all have published on that.
Yeah, I mean, I think there are a couple of things. First is just to say it out loud, it's hard to imagine a technology that is more hyped than AI. And so the first piece is, you know, when I talk to folks, like bring your native skepticism to the table, just like for new device or drug or things like that. AI is a new technology fundamental in the same way that connectivity is a new technology fundamental. But it is important to it. And, you know, since you brought it up, we have spent a bunch of time trying to show our work in the space. And I will, if I can make Zoom work correctly, sort of leave a little breadcrumb there. The way we think about AI is we think about in health that there are three big areas that we can lean in and be helpful on. The first of those is we want to help people in their daily lives. So thinking about consumer health, things like how do we lift up the best information on platforms like search and YouTube and maps. Turns out to be a non-trivially difficult task. How do we identify misinformation and show it less prominently or remove it? Then we work to bring the newest technology to bear to help caregivers and care teams, doctors, nurses, hospitals, community health workers, and everyone in between. So examples along those lines are things like diabetic retinopathy screening, which we've done in partnership with Verily, or we have a randomized control trial in the field asking whether we can shorten the time to diagnosis for breast cancer. We also have a tool that tries to bring 20 years of engineering on search to the bedside to help doctors and nurses find the information they need. And then the third area that we think we can lean in on is around community context, because we know that where we live, work, learn, and play determines the majority of our health outcomes. Examples there are things like we use ML and AI to do flood predictions. In some countries, we sent out more than 115 million alerts there last year. We know that road traffic deaths globally are the leading cause of death for people ages 5 to 29. So we have features on maps that help people take safer routes, things like that. And so those are the three areas of big company, but consumer care teams or caregivers and community context.
Well, thank you, Mike. And, you know, Ed, Mike was just talking about this broad global context. I know that you've been involved with, you know, at the Permanente Medical Group and within Kaiser Permanente, thinking about AI applications in a clinician's world and life. Maybe you can touch on what that work has looked like so far.
Yeah, absolutely, Steve. Thank you so much. It's a wonderful question. You know, I like to refer to AI as augmented intelligence rather than artificial intelligence, because I think of this technology as being a set of tools that assists and augments the physician's ability to care for patients. It's not like, unlike other ways that we support our physicians with clinical decision support tools, AI just happens to be more advanced and more complex than other types of decision support. So, you know, we're using AI in a variety of ways at Kaiser Permanente, including use cases related to natural language processing, computer vision, and predictive analytics. So I'll give a few quick examples here. With natural language processing, we're analyzing emails from our patients and categorizing the emails based on topic that the patient's writing about. And that gives us the ability to ensure that the most appropriate member of the care team is addressing the message, so that each team member is practicing at the top of their scope. And of course, this helps our patients get timely responses to their health concerns. We're also looking at computer vision and, as Mike mentioned, analyzing diabetic retinal images. We know that diabetes is a leading cause of blindness, and considering the number of diabetic patients we have, using a tool that helps us determine whether a patient does or doesn't have diabetic retinopathy can allow us to identify retinopathy sooner, which gives us the best chance to prevent someone from going blind. And then finally, there's predictive analytics, which I think of as the crystal ball of medicine. We've been developing a number of algorithms to help us do things like stratify our COVID positive patients so that we can better anticipate which patients are at highest risk for developing more severe symptoms. We also have our Advanced Alert Monitor program, which helps us keep an eye on our hospitalized patients in real time and predicts which patients are at risk for deteriorating and may require transfer to the ICU. So this gives us the opportunity to intervene before our patients get sicker. And in the case of our Advanced Alert Monitor program, we've estimated that we're saving hundreds of lives a year, and that's actually a fairly conservative estimate. And to circle back to what I started with, all of these examples are of AI augmenting the care of our physicians and our teams. And when combined with clinical judgment, we create the potential for significant improvement in outcomes for our patients, as well as efficiencies for our clinicians and our health system as a whole.
Thank you, Ed. Vivian, I was reading up on Verily, and the statement that it's Google's purpose-built healthcare company. I'd like you to sort of touch on that in the context of AI. And I was reading some of your earlier comments, just online about how Verily hopes to allow people to enjoy healthier lives. So what does that mean in the context of what we're talking about today?
Yeah, thanks, Stephen. It's great to be with this group. And actually, Michael was one of the first people to welcome me to the Alphabet family, and we enjoy a really wonderful partnership with John and the Mayo. So this is just terrific. And so to answer that question, many people are curious about who is Verily and our relationship with Google. So in brief, we are actually sister companies with Google, although Google is a much, much larger sister. We were created when Google became Alphabet a few years back. We were part of Google X, and then became one of the bets of the Alphabet family, originally focused on clinical trials, accelerating the bench to bedside transformation. And then I was recruited about 4.5 years ago to really help us focus on the care delivery and payment side of healthcare. And we partner very closely. Michael and I work very closely together. And for example, in the work on diabetic retinopathy, we are commercializing the diabetic retinopathy camera that we hope will leverage the amazing AI algorithms that Michael and his engineering teams have built over the years. So that's just one example. The kinds of ways in which we're thinking about AI are very much in line with what you've already heard about, especially, I'd love to learn more about what Ed described that Permanente is working on. We really do see AI applications now pretty much ubiquitous. How do we really extract more value out of the data that we have? And as John pointed out, highly curated data is incredibly helpful for making these tools more effective. I'll just give you a couple of quick examples, and I liked Ed's language of augmented intelligence. We have a few of our businesses are focused on, for example, supporting people who have chronic diseases, including substance use disorder, for example. And typically, when it comes to managing the population from an insurance perspective, we think of it as more or less a one-size-fits-all. We might use some historic claims data. So in Granular, which is our stop-loss insurance business within Verily, we're actually using AI to think about how can we be more precise? How can we understand more specifically the risks that an individual has, diabetes and an SUD, for example, or hypertension and some psoriasis, and not only improve our ability to estimate the risk, but then I think it is the examples that Ed was calling out, really help intervene and reduce those risks. Another example is tools that use the same kind of thinking for physicians who may be, for example, charged with some kind of quality improvement or cost reduction target, let's say, reducing length of stay or readmissions, for example. and then using some of our AI algorithms to not only identify who is at higher risk for an increased length of stay, but what are some of the system level drivers, the typical Friday discharges, or say patients who aren't fully completing the ERAS guidelines, those kinds of things, and surfacing those to the clinicians to make those data more actionable.
Thank you, Vivian. Fatima, I know that you've been interested in AI for a long time. I was looking at some of the applications that you've applied to either risk prediction, stratification, social determinants of health, pop health. So I'm interested in your perspective on, the future of what AI looks like in those contexts, and really Salesforce's interest in this arena as well.
Yeah, thank you so much for the question. As I'm listening to everybody else on the call today, I feel like I've lived a day in the life of each and every one of y'all. Dr. Halamka, just listening to your story about how you had to normalize and standardize the data and really start to make sense of it. That's pretty much where I started. I ran research and development for a company called Allscripts. The HR company had tremendous amount of data on longitudinal lives that we had to basically make sense of, right? From millions and millions of lives from across the country. Came from 9 different systems, had to solve for interoperability and making sure that data was truly standardized before we could do any outcomes research. That work took me the better part of 2 or 3 years that I'm never going to get back from my life. It was lots of fun, but certainly from there was able to show that we could do early research, from a longitudinal perspective on patients who had prediabetes that were progressing towards diabetes, and then start to think about what you might do from a clinical decision support perspective on defining these algorithms and getting them back to the point of care where they can truly make a difference. As I lived all of these lives, one of the things that kept hitting me over and over in the face is that healthcare is incredibly highly regulated. It is highly complex. There is zero room for error. And as I thought about really being able to make an impact and enable equitable access to care and enable reducing the problem of clinician burnout, I realized that the patient is going to actually be the today's empowered patient of the future, right? And that they're going to demand the change. And when they see the value, the policy will align and the technology will be able to execute at its potential today. And that's why I'm at Salesforce, because I feel that with that patient at the center of the universe and thinking about it to that angle, I can make the biggest difference possible. And so today I'm working on things, again, such as enabling access to care seamlessly and easily from a patient perspective. I work on reducing a lot of the business processes that are so responsible for clinician burnout. And no one organization is really going to solve this alone, but I'm certainly a place where I work every single day to figure out how we can make the system better.
Thank you very much. I know that we've heard from each of our panelists, and we want to hear from you as well. And so we have a question for you, and we're going to put up a poll question. And here's the question. What AI approach do you see having the most potential to improve clinical practice? Is it risk prediction? Is it voice charting, integrating data from wearables, digital health coaching, diagnosing hard to see conditions? So we're going to have this up here for about 30 seconds. Please put in your answer to this poll. While we're waiting for answers, Fatima brought up, I think, a really interesting question, the regulation question. I can't resist asking about it. So Mike, let me direct this question to you. There's a rule out there in the Federal Register, 1557. They're actually taking comments right now from companies, from experts. And the question that has arisen around algorithms, whether they're AI, ML, or otherwise, is a question of equity. And how do we ensure equity? Actually, how do we even define that? How are you thinking about it? How's Google thinking about it? You're in the algorithm business.
Yeah, we think it's a fundamental part of the quality of care. So if you go back to the Institute of Medicine statement on what is high quality care? It is safe, effective, efficient, person-centered, timely, and equitable. And there is deep evidence that care that isn't equitable just isn't high quality. So that's number one. About 4 years ago, we took the pretty unusual step at the time of publishing a paper in Annals of Internal Medicine about the way that we were thinking about both the policy issues and the technical issues of equity related to algorithms. And so just to say that everyone should have the opportunity to achieve the full benefits from AI from their healthcare system, and that we should work systematically to eliminate those barriers. So there are a few places where that happens. One is in the care system itself. The care system itself is not full of equity, it is full of disparity. Therefore, the data that we collect has the disparities built into it, even if the data collection process is fully equitable, which it usually isn't. There are technical choices you can make in algorithm development that may enhance or worsen that. But for the epidemiologist on the call, missing data that is missing through a non-random mechanism is one of the most fundamental, statistically difficult problems that may not have a solution. So it's very hard to deal with that. And then finally, thinking about how an algorithm or a predictive model is used in practice is another place where this can creep in. And finally, it's really important to monitor the performance of these in practice as practice changes in response to a predictive model, and as practice as people who come to a given health system changes. So it's really across the entire life cycle, from the very beginning of the first time you're thinking about using any predictive or classification algorithm. And it doesn't matter whether it's AI or a SQL statement with a group by clause, that thinking through the entire chain from first idea until taking care of people and after is one of the key elements for them.
Thank you, Mike. Now, John, I'm going to turn to you for a second here, because you raised the earlier question around data integrity. So on top of like somehow monitoring an AI and ML algorithm that is presumably changing on its own over time, black box, and yet we've got to monitor it somehow for all those factors that Mike was just talking about. You raised the question of integrity of the data, privacy of the data. The platform that you lead and are sponsoring aggregates or wants to aggregate different systems data to actually hopefully maybe even solve for some of these questions that Mike was raising. How are you thinking you do that? I mean, you mentioned IRBs, you mentioned other things. How do we do this in a way that our patients whose data are going into the EHRs is actually protected?
What a great question. So the promise we've made to our patients is that we will use what I'll call a multi-layered defense. And that means the data will be de-identified using the most advanced techniques available. And what I mean by advanced techniques is, imagine I have a note, and I've written in that note, this patient, who is a significant leader of all healthcare at Kaiser Permanente, you could imagine there are things in the note that are not a name. They may be a geography, a familial relationship, or a job role. We had to go in through natural language processing and take all the proper nouns and do something we call hiding in plain sight, which is, instead of saying this leader of all things healthcare for Kaiser Permanente, it might say, this medical leader at Yale, right? That is, you've changed things in such a way that they're harder to re-identify. Though we bring in partners and joint ventures and collaborations into the de-identified data, we do not allow what I call linkage. And you may be very familiar with the very famous, in the 1990s, LaTanya Sweeney took the de-identified data from the state of Massachusetts and the Cambridge voter registration rolls and linked the two and found that William Weld was the only person of his age in his zip code and was able to re-identify his medical record, including all of his medications. Now, she did not broadcast that. She just let Mr. Weld know that this was not a secure system. We do not allow that kind of linkage in an attempt to re-ID. Everything is audited, and everything ensures that what can leave are discoveries, but not the data itself. And in that respect, the patients and all that we, government, academia, and industry stakeholders we've spoken with say, you've actually taken a very reasonable approach to doing good without doing harm.
Vivian, I'm gonna pivot for a second here. So, Mike actually started his comments with, we need to have a fair amount of skepticism around, AI and ML, and in terms of both its promise and potential issues. So you mentioned, making clinicians' lives better, and I'll just speak as a clinician that I've heard EHRs were going to make our lives better, right? And there's a lot of healthy skepticism out there about that. What do you think in terms of, it was interesting. I was just looking at the poll results, and there were 17% or so that were saying, that maybe this is going to help me with charting or help me with my clinical life. Where do you see the opportunities?
Yeah, that's such a great question. And I think you're hearing pretty consistent messaging from everyone on this panel that that's really a focus for all of us in terms of how we want to direct the AI tools, ML tools that we have. And right now, I think we're at a pivotal point where there are enormous number of opportunities, enormous number of directions that we can take. And so it's important to both John and Michael's points, and Fatima and Ed's as well, which is that I think it's important for us to set the expectations and the standards for what we are hoping to get out of these tools going forward. So we've heard very clearly articulated, we need to make sure that there's highest levels of data privacy and security. We really need to be very attentive to bias and health equity. So for example, I think it's really important, in all of our businesses, we monitor the enrollment, engagement, and outcomes in terms of their impacts on our patients and our members or customers, or however you want to call people, in terms of different measures of social determinants and health equity and disparities, for example. I think, and then there's a very interesting question also in the Q&A about measuring ROI, measuring the actual impacts on health outcomes or cost of care or access, and how are we ensuring that as we deploy these algorithms, we're actually expecting people to measure both the intended consequences and some of the unintended consequences so that we can make sure that we're not deviating. I think those are all really key components right now in laying that groundwork so that we can make sure that the work we do has the best possible impact.
Ed, there was a lot of interest, with the poll around predicting the future. You mentioned a number of different, applications. What should we be thinking about in terms of where are the targets? I mean, how do you think as you're part of a very large healthcare organization, where is the biggest potential impact, and how do you make those decisions, and who do you engage?
It's a great question, Steve. And I did see that risk prediction got the highest selection there. And I'd like to think that my crystal ball comment may contribute to that, because who doesn't like a good crystal ball? But I think the thing about risk prediction is that it can affect not only individual patients with the output of what we predict, it can affect entire populations, entire communities. And so that's the power of what we've been discussing here, where we can positively contribute to the health of many, many patients. And with the limited number of resources that we have across the healthcare industry, we need to focus our efforts on how do we get the biggest bang for our buck. And so, we know that hospital readmission is very expensive, and it's costly for the health system. It's costly for the patient. Sepsis, where a patient can get severely ill and potentially pass away. How can we predict that type of outcome and prevent that from happening? And so, looking at things that can negatively affect the patient the most, or alternatively positively improve the health of the patient, I think is the way that we want to try to approach this. And then looking at the number of patients that we can help with these types of tools is the other way, so that we can make the biggest impact using the tools that we have.
Fatima, I'm looking at the chat as it's coming in here. Lot of discussion about applications, potentially outside of the US. What can we learn from it? I know you've done some work with extension beyond the US. I'd be curious in, sort of your take on that.
I think, when it comes to US data, unfortunately, bias is just inherent in the system. When you think historically about the data that has been available, right, and just the historical lack of access to care, the US data sometimes suffers from not being as inclusive as it could be, just, from that access viewpoint. You look at other countries, and they are ahead of us, perhaps, in a few different ways. Number one, when they have public health systems, often they have a national patient identifier, a single identifier that follows the patient from birth to death, and is a great way to identify what is truly happening. Secondly, with more, I'm going to call more authoritative governments, perhaps, there is this acceptance that there is this ability to follow a patient and track. And I think over here, one of the things we're still facing is, what are you doing with my data, right? We have not necessarily seen the value in the US out of giving up the data to its optimal potential, and therefore there might be some animosity, but we certainly have seen it in other countries where, again, it is just accepted, and the ability to do this kind of outcomes research and figure out where the problems are a heck of a lot easier. Case in point being COVID, and just being able to track who was where, and just identifying cases.
Thank you. I can't resist. There are a couple of questions here about adoption, okay, and the length of adoption of really almost any innovation when it comes to healthcare, and we're notoriously slow. So I'm going to ask this question of both maybe a technology expert as well as a health system expert. So John, you're a little bit of both. What do you think? I mean, how long is it going to take for healthcare, the industry, and practicing clinicians to adopt this?
Well, William Gibson already told us the answer, which is the future is already here. It's just unevenly distributed, right? That is, at Mayo, when you get a 12-lead ECG, 14 algorithms are run on every 12-lead ECG taken at Mayo Clinic. We print the result of all the predictive models on the ECG itself. So that is, typical ECG, rate, rhythm, intervals, that sort of thing. But we actually can tell you, what's your ejection fraction? Do you have pulmonary hypertension? Do you have hypertrophic cardiomyopathy? Will you have AFib 3 years from now? Right? It's on the ECG itself, so there's no cognitive burden. There's no button to push, app to download, or distraction outside of the EHR. So I think as you look at these next, say, 6 quarters, let me use 6 quarters, we're going to see more and more of this kind of thing being brought into the EHR workflow itself, so that this human augmentation, which is exactly the right term, is just simply going to be there. And here's why I think that's so wonderful. For the last 20 years, we've all thought the EHR was going to make medicine easier. And I think what we discovered is it takes but never gives. And what we're hoping is you start to get this augmentation is, oh, have you thought about this diagnosis? Some other clinicians have ordered this lab test in this circumstance. It's up to you. What do you think? That in the next 6 quarters is going to become standard as part of EHR workflow, my prediction.
So Mike, I'm going to ask you similar question, but a little bit of a twist here. So there's the buy-in question, and then John was just alluding to this, and what came to mind for me is the insight, with the diabetic retinal algorithm that you all put in place. That of course it's not just detecting diabetic retinopathy. And of course, the first insight that I think probably made everyone wonder was that it can tell whether or not you're male or female based on that algorithm. So how do we get people to actually understand or buy into those additional insights that wouldn't have been inherently, at least to me as a clinician, something that I would have gotten from that kind of information or algorithm?
Yeah, it's, I spent most of my career as an implementer and a quality and safety person in health systems, right? So my career has been about this, bridging area of healthcare delivery science between like do stuff in the real world and use research quality math. And one of the things that is really rich about this conversation is for many years, we hear, big data is only related to genomics. But in fact, if you looked across the Kaiser Permanente hospitals and asked how many options do you have for nurse staffing tomorrow, before you start adding rules on top, the answer is probably a number larger than the number of atoms in the observed universe. And so the things that we take for granted on a day-to-day basis are truly complex. And so of course it takes a long time for things to for things to make progress. But this conversation is a good example of respecting the difficulty of caring for patients and running health systems. So that's one. And then let me answer your actual question, which is about the diabetic retinopathy work. So for background for folks, we worked on, can you use a neural network to detect signs of diabetic retinopathy? We subsequently did a study asking, can you predict the risk of 5-year major adverse cardiac events from a diabetic retinopathy, from a fundus picture from the back of the eye? And the answer is yes. And that's not so surprising because you can literally see the vessels. And I remember C and V, like one of them is vascular. Great. But it turns out that in that same study, they showed that you can predict someone's self-reported sex with an area under the receiver operating characteristics curve of 0.97. And the interesting part of that is not that neural networks can do that, because there are much easier ways to ask people what their self-reported sex is. The interesting part is if you ask ophthalmologists to do that, they lose their minds trying to do it. They're like, that can't be done, it's impossible. It turns out that it can, and that it works, and it works across a number of areas. So I do think that there are a few places where we're going to see that AI can do things that we didn't think were possible. And probably the best example of that is from another sister company, DeepMind, has more or less solved the protein folding problem, which was thought to be essentially intractably difficult to do at scale. They just won the breakthrough prize for that. And so I do think that we'll see a few of these areas which are like looking around the corner and seeing the future. But most of it will be the equivalent of upgrading from doing account. Most of it, I agree with John, over the next 4 quarters, 6 quarters, whatever, will be the equivalent of upgrading from doing bookkeeping on a ledger with a 10-key calculator to Lotus 123. It'll be a big improvement, but it'll seem like it should be, like we should be able to do it.
This will be, I think, just mark it in our books that we had a Google person talking about Lotus 123. I mean, it's so let me ask a question. This is probably for both Vivian and Fatima. Questions about our aging population, aging patients, and their need to probably benefit, right, from AI, ML. Increasingly, we're providing more care actually where the patients are, as opposed to in our clinic or in a hospital. It's in their homes. They're caregivers. Not all these folks are, and again, I don't want to, I'm taking and sort of paraphrasing this question here, and it's because it shouldn't be ageist here, because we got a lot of tech-enabled seniors. But how do we make it accessible to seniors? I mean, what's this going to look like for them in terms of improving their lives in their homes and their interfaces with the clinical teams?
I think there's two specific areas as I think about this question of the aging population where this can truly make a difference. Number one, there's a huge avenue called remote patient monitoring that has taken off. And as we think about the aging population and even the role of the caregiver in taking care of them and figuring out how to keep patients in their preferred, potentially home environments longer, there is a huge role for sensors, for being able to complete that monitoring, keeping the patient comfortable wherever the heck they are, and actually just leveraging the power of the data and the algorithms to highlight when additional assistance is going to be needed. So I think there is huge amount of potential here. And again, we're just starting to get to that, tip of the iceberg where we're just starting to make a real difference in the needs of the patient so they can stay at home. I think, again, the other key area is in that of the caregiver. There's a lot of us who are part of that sandwich generation, right? We're managing kids, we're managing our parents, we're managing our own loved ones. Even as physicians, we're thinking about them from the patient perspective. And if we can figure out how to enable being able to do that easier, there's a huge amount of potential there. If I can schedule or have automatically scheduled appointments for a home health aide or a nurse to come by to manage my aging parent in their home according to my schedule when I'm not going to be home or when I know there's a meal that's going to be needed, wouldn't that start to change the way we view wellness in the home?
Vivian, your thoughts on this?
Sorry, I had to disconnect and come back, but I think the topic is really around engaging. Is it around engaging patients? Is this the?
Well, yeah, a little bit of engaging patients and also in the aging population. So, and for the aging population that may or may not be completely tech facile, how are we going to incorporate AI, ML into their lives?
Oh, such a great question. Well, I think this overall theme of really thinking in a much more patient-centered mindset from the beginning is something that I've found really refreshing in the tech side. I think Michael alluded to it earlier from just saying, hey, we're thinking about health from the perspective of people's daily lives. And maybe I'll say one comment about the general and then maybe specifically around the elderly. In general, I think one of the observations that I've made since moving from healthcare, having been in healthcare my whole life and leading those systems, is that there's really a lot of work, a lot of opportunity around how we think about engaging people and understanding what is important to them, which means collecting whole different kinds of data, sort of a little bit alluding to what Fatima was just saying earlier, whether it's explicitly patient-reported outcomes or doing what we call A/B testing, where we present different kinds of motivational language to people if we're trying to engage people in helping them lose weight or manage their diabetes, for example. And sort of thinking more, we traditionally we use the word precision medicine, but how do we move more to precision health and precision engagement, whether it's language, cultural, or just different people are feeling different on different days, and how do we really engage them? And there are a lot of ways in which our AI tools are really helping us gain those insights. With respect to really thinking about populations that may not feel that comfortable in just typing on 12-point font on their phone with their thumbs, I think there are just tremendous opportunities here. And Michael can speak more to some of the things that are happening across the broader Google landscape. But different ways of engaging with our patients, I think, is really important. We've been seeing a lot of success with our various chat and chat bots throughout the pandemic in different forms, but thinking about that both in terms of voice recognition, speech, the ways in which we can engage people more than just simply on their phone. Now, those are just natural extensions. But again, no matter what the medium is, realizing that the way we engage people so that it is just as personalized as their genome, thinking about their psychology, where they are, what their motivations are, and really engaging people. To me, that's kind of the holy grail of what we need to do across all of healthcare, and where AI has so much to offer.
John, I got a question for you here. It's coming up. It's the I word, interoperability. And the holy grail, bane of our existence. I've heard you talk about platform thinking. What does interoperability look like in the future? And can we do anything better than what we've done in the past when it comes to AI and ML?
So what a wonderful question. So, I've been working on this for 40 years. And so you have to ask the question, have we made progress? And I would assert yes. Right? So think about what we have codified fairly well. Problems that are encoded in SNOMED and labs in LOINC and meds in RX norm. That's actually, if you look at these last 2 decades, mostly through things like Care Everywhere, Commonwealth Alliance, and other ways, you can bring all that stuff together, but there is a challenge. And sometimes our problems are technology, sometimes they're policy, but sometimes they're psychiatry. And what I mean by that is this ability to bring multiple organizations together to collaborate for the benefit of society. What we're starting to see are a couple of different models. So since Vivian is here, I'll mention Terra. There is an open source product from Verily that says, Kaiser can put its data in this secure container. Mayo can put it in that secure container. Mayo and Kaiser can't see each other's data, but yet we can do algorithm development across both. And there are 4 or 5 other technologies that are enabling this kind of collaboration without necessarily requiring the centralization or giving up control. So I actually feel very positive about where we're headed. We've done the interoperability where interoperability is needed for structured data, and for the unstructured stuff, we've figured out secure computing technologies that foster discovery without compromising privacy or reputation.
Thank you, John. There's a lot of questions, Ed, coming up around quality assurance and monitoring. And I know that you're sponsoring a group, the Augmented Clinical Intelligence Group within Kaiser Permanente, to try and tackle that. Can you talk a little bit about what that's all about?
Yeah, thanks, Stephen. Whenever we put out these tools, we need to make sure that they're still doing what we intended them to do. When it doesn't start or stop at, okay, we've created something, now it's out there, let's go ahead and use it, because maybe that'll work for the subset of population that the algorithm was developed upon. Or maybe it works in the beginning, but as more data is collected and more information is available, the algorithms really should evolve and continue to develop so that we're making sure that we're providing the most equitable care as possible, and make sure the algorithms are still doing what they're intended to do. And so that really involves validation, revalidation, and then revalidating again. And part of it, though, is that if you don't look, you'll never find bias. And so you need to make sure that that's built into the process in which these algorithms are used, developed, and continue to be maintained. And so as we continue to develop many of these tools here, that's how we're looking about it. We're making sure that it doesn't stop once things are put out there. That's just the beginning.
Thanks, Ed. Hey, Fatima, I got a question for you here about, I think it's an interesting one, engaging our patients, and the question around gamification. Does AI have any role with that?
Absolutely. I think AI is core to gamification, right? Really understanding what are the motivators behind behavior change, behind adherence to care plans, behind really, again, making that change in individuals' lives, or what treatments are going to work. So there is a huge amount of potential. We are starting to see the benefit. There are a number of smaller disruptors that are absolutely heads down focused on this space, and they've had a huge amount of success actually leveraging this stuff, especially in the areas of diabetes and chronic condition management.
So Mike, I don't think any of us went to medical school and learned about AI, or at least maybe those of us that are long in the tooth here in the room. How do people learn more about this? I mean, where do they go to get more educated?
Yeah, I mean, I've talked to a fair number of educators. You know, when you go and look at the curriculum for undergraduate medical education, it's really packed and really difficult to think about. I don't think that this discussion is necessarily any different than the 20 years ago, the evidence-based medicine discussion, or the user's guide to the medical literature. And so I do think as we think about medical education, there will end up being some balancing of what's taught today versus what will be taught in the future. You know, where do you go down to learn about it? There's some. I saw a question in the chat. There's some good conferences around AI, and one of the nice things that has happened over the past few years is you don't have to go to specialist conferences anymore. You don't have to go to AI Med is one that people go to. That in specialty societies, AI, just like any other technology, is becoming a track in most of these and integrated into the work. And I think that that's likely how it'll play out over time. The one thing that I'll add is we're in a growth phase right now about technical capability of AI, moving just over a period of a few years from we can do little small images to we can have dialogue with people. And so it will remain fast changing, I think for a while.
Yeah, John and Ed, I got a question for you, and this will expand it beyond just the physicians. It would be any clinicians being touched by these nowadays. And there was a recent actual proposed legislation in one state looking at the potential for a clinician to override algorithms, which I think raised for me a question of how do we educate the greater healthcare workforce around algorithms, what they mean, what they don't mean. What are you doing in your own institutions to try and address some of the either opportunity and or concerns that have arisen around AI and ML?
Sure. So Mayo has actually created a small group called AI Enablement and Education. And this small group is designed to take the entire workforce and enhance their knowledge of AI, both from a development and use perspective. Let me tell you why I think Kaiser is magical. So remember, I was a Southern California and a Northern California Kaiser member for much of my life. You have amazing clinical expertise, you have data, and you have good tech resources. And that combination is essential to creating good AI. Let me give you a quick example. A not physician looked at a bunch of data I provided and said, I have noticed I could create an amazing model that if you give your inpatients high-dose morphine, their readmission rates go down. Now, I think all of us would agree, well, that may be true, and that's highly undesirable. So your clinician expertise is absolutely key to ask the right questions, and with a bit of enablement and education, potentially even working with the technologists at their elbow, they can create models which have clinical relevance, fairness, and utility.
Ed, any additional thoughts from your perspective?
Yeah, I mean, I think what John said was spot on. I mean, I think that technology is only so useful when it's just out there sort of standalone, but really combining that with clinical expertise is when you really can make the difference in the lives of the patients. And so, taking things out of context is not the way to go. But if you work together with the clinical experts to say, here's the problems that we're trying to solve, here are the important things that are making it challenging for me to take care of my patients, and working together with the technology groups to say, here are the solutions that we've got available, here are the tools that we have, and here are the solutions that we can bring forward. That's when the power of AI comes forward and when we can actually really make the difference in our patients' lives.
So this has been a fantastic panel with incredible thought leadership. So we're going to do a lightning round, minute or less. What makes you personally the most excited for the future as it relates to AI and ML and its application to healthcare? John.
Okay, so you've probably seen in my writing that I believe the perfect storm for innovation requires technology that's good enough, policy that's enabling, and cultural change that creates a sense of urgency. As many of the folks in our panelist group know, my mom, who's 80 years old, is quite ill and is receiving hospice care. My mom, before she got seriously ill, had never touched a keyboard. She learned to become digitally enabled because it was the way she could reach her clinicians and seek services. There's a cultural, absolutely demand of our patients to do this. And as Michael said, we now have storage, we have compute, we have tools. As you said, the policies that are now getting promulgated are going to give us guidelines and guardrails, but the cultural change and the demands of our patients will drive us forward.
Thank you. Mike.
Historically, if you look at the introduction of new technology, it doesn't help for 10 or 15 years, 20 years. So if you look at when electricity went into factories, they didn't redesign the work. They just, it took 10 or 15 years to figure out that you could have little motors at every station. Same thing in banking, same thing in other areas. Well, we're at the right time right now to begin to redesign work after the digitization of US healthcare. That's an unprecedented time in history. And it's exciting to start to see these little areas where the work is being redesigned, not just we're adding technology.
Thank you. Ed.
Yeah, Steve, I think the future is really bright when it comes to AI and healthcare, and I see a tremendous amount of potential. I think it's about doing what's right for our patients, to improve care, to help our physicians make the best decisions possible, to decrease the amount of stress and burnout. And I think it's incumbent as leaders in this space to design our AI products to bring equity and inclusion to these tools. And I think in 2 to 3 years, if we bring this panel back together again, the conversation would likely have many of the same key foundational elements, but the applications and the AI that we would have developed and deployed would be much more advanced, I think, and about what we're talking about today. And so I'm really excited to see what we're going to shape the use of AI into the future.
Thank you. Vivian.
Yeah, I really believe that the advances that we're making now are going to enable us to do really personalized care at scale, that we're going to be able to create truly co-produced health, that patients, their families and caregivers, as well as those of us on the provider side are going to be able to team up and make it a truly personalized experience, both biologically, pharmacologically, as well as from a sociological perspective. And what gives me the greatest hope is the fact that this whole panel is so engaged, that this time these tools are not being built by people who don't understand anything about healthcare, who don't think that don't really understand our problems, the more all of you on the call are really engaged and know the problems that we need to solve and know the guardrails that we have to be mindful of and can really participate in this, the better. That's what makes this future so bright, I think.
Thank you, Vivian. And Fatima, you have the last word.
I think technology and AI can contribute to either being the greatest enabler or the biggest barrier. I think we are in the era where the barrier is going away and technology is becoming that great enabler. And I think that's fantastic. And it leaves me feeling like we are in a space where we can deliver more equitable access to care on demand, wherever, whenever our patients need it. We can actually be in this space where we're reducing burnout and decreasing the work of medicine. And so I'm incredibly hopeful about the future. And I think there's a huge role for technology to be part of it.
Well, thank you. And I want to thank all of you, our guests, for taking the time out of your busy day to participate in this webinar. Thank you all for joining this webinar and tuning in. And we will make this recording available after this session. I want to encourage all of you to tune in to an upcoming Permanente Docs chat on October 27th, where we will continue the conversation of AI and its use in healthcare during a live Facebook chat. Please check the Permanente Medicine Facebook page for more information. Thank you all for joining. I want to wish everyone a happy Rosh Hashanah for those who are celebrating the new year today. And thank you all and be well.